question that was posed is, why is science important to surgery?
In some ways, I feel like this question is like, why would research not be important to surgery?
Can you imagine engaging in the process of care and seeing patients with less than optimal outcomes, patients who are struggling with common disease processes that we don't have an answer for?
Without research, surgery will be reduced to a technical exercise, and we will still be doing procedures like radical mastectomy for breast cancer.
We have a lot of knowledge and a lot of know-how. We actually don't know how to deliver good care all the time to every single patient.
I like to go back to a quote often used by one of our shared mentors, Tom Crummell. It was taken from Francis Moore. That quote is that surgical research is anything that gets the surgical patient better. What I love about that is that it really defines what we do and why we do it. The what can be anything from molecular biology to stem cell to devices to evolving digital health solutions. And the why is quite simply that the status quo is not good enough. We need to find better ways to treat our patients and deliver better outcomes.
We see disease, we see it with our eyes, we touch it, we remove disease, we take care of some of the sickest patients in their most dire times. And how we do that, how we understand the disease, our contributions to how we can better improve the care of patients, the safety of care, the quality of care, develop novel treatments that will improve the outcome of their treatment are really so impactful. So, and if we don't do research, we're gonna leave out so many important discoveries and findings and things that will impact generations to come.
Research is critical to the development of scientific surgery. Surgery should be based on studies and science.
There are three reasons in my mind. First, when you operate, when you do surgery, you only impact one patient at a time, but with research, you impact so many more.
With surgery, you cure one patient at a time. With research, you cure many patients at a time.
The really great thing about research is that you can have a multiplicative and even exponential effect on patient care, not just one patient at a time, but thousands of patients at a time. The key is building upon what others have done, sharing what you've created so that others can further build on what you've done.
Number two, chance favors the trained mind. And as surgeons, just the amount of training we've had and the skill set we've acquired, we are the best suited to figure out what are the new questions that need to be answered, what are the new hypotheses. And we are the best suited to improve surgical care.
Surgery benefits from research, and research benefits from surgical approaches. And together, the two drives us to new discoveries in science and new possibilities for improving human health.
My feeling about research is that it's very exciting when suddenly it works and you get important information that only you understand and can communicate to others.
And number three, we owe it to our patients. Our patients come to us in a very vulnerable time in their lives. After any procedure, their life or their body is not the same again, however small it may be. And so we owe it to them to figure out how to innovate, how to deliver the best possible care, how to improve surgical quality, and how to develop new techniques like minimally invasive surgery.
One of the most important goals of academic surgery is to come up with new ways to help our patients. And research is the scientific way to help us get to that goal.
In the end, the reason we do this is to improve patient care. Whether it's through a better understanding of the pathophysiology of disease, ways to improve the clinical care that we provide, or trying to understand processes and the efficiency of care that we provide. In the end, the goal of it all is to improve care for the patients.
Urgent surgery is extremely important if we are to impact patient management that would hopefully result in improved outcomes.
Outcomes research is important to surgery. because it helps us to critically evaluate our own work in an organized and objective manner. While large national databases effectively demonstrate complication rates, I can offer you more granularity about specific outcomes when I look at my own registries.
Part of research's role is to put surgery in the context of a bigger system of healthcare. That we understand that surgery is a really important part of the health system, but not everyone really recognizes that. And so ensuring that that's understood and recognized, ensuring that it's integrated into a health system, and ensuring that a health system is able to deliver such complex care.
We will not accept the status quo. We will not accept borderline or poor outcomes, and we will make a contribution to a better place.
Research is our currency, and we hold it very highly.
Research is where the future of surgical care gets advanced and reinvented. From the earliest days, all the great advances in surgery, from gastrointestinal surgery to solid organ transplantation, cardiovascular surgery, total parenteral nutrition, on and on. All of these advances have their roots in the great surgical laboratories. And really importantly, almost always, these advances have been based on the work of surgical residents.
Engaging residents in research, especially on this 12th annual Resident Research Day, really provides new insight, fresh eyes, a new way of looking at problems. It also provides an opportunity to engage our residents in critical thinking and learning ways to analyze problems and look at data with new ideas. And this really just keeps us all fresh. It also allows us the opportunity to mentor and develop relationships that they can subsequently pay forward.
It's great to have this day to celebrate the amazing research done by our department and to look forward to the future where these will impact the care of future surgical patients.
Great. All right. Well, it's a few minutes past 3. We're going to continue on in the program. Next up, we have the best clinical abstracts from this submission this year. And our moderators for this session will be Dr. Cindy Kinn and Dr. Kara Liebert. And I'll turn it over to them.
Thank you. All right, so I just want to remind everyone that you can submit your questions using the QR code on the back of your pamphlet. Again, these presentations will be 8 minutes long and 4 minutes for questions. Our first presenter is Dr. Wilson Alobuia. He's going to be talking about racial disparities in the utilization of parathyroidectomy among patients with primary hyperparathyroidism, evidence from a nationwide analysis of Medicare claims.
All right. Hi, everyone. Thank you so much for the opportunity to present our work today. I have no disclosures. So primary hyperparathyroidism is a very common disorder of mineral metabolism, and it due to excessive secretion of parathyroid hormone from one or more abnormal parathyroid glands. Clinically, the disease is characterized by hypercalcemia with inappropriately normal or elevated parathyroid hormone levels. And this leads to osteoporotic fractures, kidney stones, chronic kidney disease, and in some patients, neurocognitive symptoms. The incidence and prevalence of primary hyperparathyroidism has been increasing, especially among older Black women. Parathyroidectomy actually offers a pretty good chance of, or excellent chance of cure and mitigation of disease-related complications. The operation is actually very common, safe, and very effective for primary hyperparathyroidism. So despite the increasing incidence and prevalence of primary hyperparathyroidism and the effective nature of parathyroidectomy, the use of parathyroidectomy has actually been decreasing over the last few years, even among patients who meet operative criteria, as you can see in this graph. So previous single institution studies have shown that African American patients with primary hyperparathyroidism are more likely to have more biochemically severe disease and also have higher rates of incomplete evaluation. African American patients also face substantial delays in getting parathyroidectomy after they've been diagnosed. However, there's very limited research on how race and ethnicity affects patient referral and the utilization of parathyroidectomy. And so the goal of our study was to build upon these findings using a much larger patient database. Our goal was to perform a nationwide population-based analysis to investigate whether race and ethnicity are associated with disease severity, surgical evaluation, and utilization of parathyroidectomy. And so, armed with the knowledge from the literature on health disparities, we hypothesized that patients from minority backgrounds would be more likely to have severe disease, less likely to be evaluated by a surgeon, and less likely to be treated with parathyroidectomy. And so we performed a retrospective analysis using 100% of Medicare claims and enrollment data. We identified patients diagnosed with primary hyperparathyroidism using ICD-9 and 10 codes, and we only looked at patients over the age of 65 with a new diagnosis between 2006 and 2016. All patients also had at least 12 months of continuous enrollment, both before and after the diagnosis. And we did this so we can make sure that we're only including patients in whom insurance coverage was not a barrier to seeking initial evaluation or follow-up care. We excluded patients with severe chronic kidney disease and those who had a history of kidney transplant. We also excluded patients with prior parathyroidectomy. And so for our methods, we used a combination of univariate and multivariate logistic regression to identify associations between race and ethnicity and our outcome variables. Our model accounted for patient demographic information, comorbidity, frailty, and access to endocrinology care. We also included the Area Deprivation Index, which is a validated measure of neighborhood disadvantage in the United States using zip codes. And so the ADI serves as a proxy for patient socioeconomic status. And so finally, our three main outcomes were first, the rates of primary hyperparathyroidism-related hospitalizations within 6 months, the rates of surgical evaluation within 1 year of diagnosis, and finally, the rates of parathyroidectomy within 1 year of diagnosis. And so, as for our results, our final cohort included over 210,000 patients. The mean age was about 75 years old, and about 79% of the cohort was female. And the rate of parathyroidectomy within 1 year of diagnosis in the entire cohort was about 30%. A majority of the patients were white, 9.4% were black, 1.1% Hispanic, and about 1% Asian race, and about 0.2% were Native Americans. By ADI, we see that about 58% of the population were considered to be advantaged, and 42% were considered to be disadvantaged by ADI. And so in terms of overall comorbidities, we found that black patients were more likely to have stage 3 chronic kidney disease, but had lower prevalence of osteoporosis and kidney stones at the time of diagnosis. Black and Hispanic patients also had higher prevalence of overall comorbidities, as you can see here. So when we look at our first outcome, which was the rates of hospitalization within 6 months of diagnosis, we see that Black and Hispanic patients were more likely to be hospitalized for primary hyperparathyroidism-related complications. And now when we look at access to endocrinologist care, we see that first, white patients had higher access to endocrinologist care, and Hispanic patients had the lowest rates of access to endocrinologist care. On multivariable analysis, we found that having access to endocrinology care was actually associated with a higher likelihood of being evaluated by a surgeon and subsequently undergoing parathyroidectomy. However, we found that this association was not necessarily the case for African American patients. So here we have an interaction plot, and as the name suggests, the goal of this is to basically identify interactions between variables. If no interaction exists, you would expect the lines to be parallel. And so in this analysis, we tested for each racial and ethnic group the effect of having access to endocrinology care on the probability of being evaluated by a surgeon, as you can see on the y-axis. And as you can see, all the lines here appear to be parallel with each other, except for one, the red line, which represents the African American group in our cohort. This tells us that unlike other race and ethnic groups that we looked at, the positive effect that access to endocrinology care has on the likelihood of being evaluated by a surgeon is actually diminished among African American patients. In this graph, we show the rates of parathyroidectomy among patients who met operative criteria according to official consensus guidelines. As we can see, African American, Asian, and Hispanic patients who met operative criteria were still much less likely to undergo parathyroidectomy. This demonstrates again that the decreased rates of operative intervention for non-white races persists even among patients who met operative criteria. Finally, when we look at the impact of race and ethnicity in general on evaluation by a surgeon and eventually undergoing parathyroidectomy, we see that compared to white patients, African American, Asian, and Hispanic patients overall had lower likelihoods of being evaluated by a surgeon. And finally, African American and Hispanic patients had lower likelihood of undergoing parathyroidectomy even after they had seen a surgeon. So in conclusion, we found that racial and ethnic disparities do exist in the management of older patients with primary hyperparathyroidism, that Black and Asian race, Hispanic ethnicity is associated with less frequent evaluation by a surgeon. And finally, Black race and Hispanic ethnicity are associated with lower rates of parathyroidectomy, even when patients in these groups met operative criteria and even after they were evaluated by a surgeon. And so this study has two main implications. First, it shows that disparities exist at multiple stages along the way in the care of patients with primary hyperparathyroidism. And so this provides an opportunity for all of us to identify and directly address issues related to surgical decision-making and access to care. One main limitation of this study is that the use of ICD codes may lead to lower detection of patients with primary hyperparathyroidism, and that excluding patients who had secondary or tertiary hyperparathyroidism may exclude patients who had coexisting primary hyperparathyroidism and kidney disease. So those are the two main limitations of the study. And so as a future direction, we hope to use qualitative and mixed methods research tools to help us understand referral patterns, practices by endocrinologists and PCPs, and also evaluate how we as surgeons make the decision on whether or not to operate on patients. Secondly, there's also a significant need to find ways to address issues related to access to care and for education among physicians regarding operative indications for parathyroidectomy. It is only then that we can achieve parity in the management of primary hyperparathyroidism. I'd like to thank my mentors, Dr. Saib and Dr. Kebubu, for their incredible mentorship, and to the Lee Ka-shing Surgeon Scholars Award for supporting my scholarly activities in my PD time. Thank you, and I'll be happy to take any questions.
All right, so outstanding work. You reported that Black patients had higher unadjusted rates of inpatient hospitalizations, which was 8% for Black patients compared to 4.8% for white, potentially suggesting more severe biochemical disease, but they were less likely to be evaluated by a surgeon and undergo surgery. So what hypothesis do you have for the disconnect between this disease severity and the likelihood of receiving definitive treatment?
Thank you, Dr. Liebert. So I think there's quite a few hypotheses here. There's a few things that might explain that disparity. The first one would have to do with access to care, and especially in an outpatient setting. And so the goal is that if you have patients who have routine outpatient follow-up with their primary care doctors or their endocrinologists in this case, then they are more likely to have their disease monitored, and when it's time for them to seek care or be seen by a surgeon, they're able to do that. The second reason could also be just barriers in communication between surgeons and patients. And we've seen that in very different disease settings. And so sometimes the way we discuss risk and benefits of surgical operations can affect how patients actually understand what we're going to do. And so that might have an implication, can affect that disparity that we see. The third thing could also just be clinician implicit bias. We know that is real, and that affects racial disparities in care, in healthcare. And along the same lines, patient preferences would also explain some of this disparity, because the patient at the end of the day would have to make the decision whether or not they're going to have an operation. And those are things that we're not able to see in our database and account for. And so the goal now is to actually go back and using the database that we have to be able to look at, of all the patients that were diagnosed, how many of those patients actually ended up getting the appropriate evaluation. So did patients get DEXA scans and imaging to actually evaluate the extent of their disease? Because it's only then that you can know what patients to refer to a surgeon versus not. So those are the things that we're hoping to sort of carry forward in the future with that database.
And then another question from Slido is, did the racial disparities in your outcomes vary by geographic region of the country, for example, census region?
That's a good point. So we do not necessarily have information about census regions. So like I said, we use the ADI as a way to measure socioeconomic status. We don't necessarily have information about regions in this analysis, but I can tell you that by ADI, patients who are from disadvantaged regions also were more likely to not have parathyroidectomy or be seen by a surgeon.
Okay, thank you very much.
Right.
Thank you for the opportunity to present our work. These are our disclosures. The Veterans Health Administration is the nation's largest integrated health system, providing care to over 9 million veterans in the United States. Due in large part to contemporary concerns regarding the timeliness and quality of care in the VHA, Congress passed the Choice Act in 2014 and then the Mission Act in 2018 to increase veterans' access to private care. To be consistent with the goals of the Mission Act, veterans should receive comparable or better care in the private sector. Yet there are currently no well-delineated methods for comparing surgical quality and safety in VHA versus the private sector. Established 3 decades ago, the VA Surgical Quality Improvement Program, or VASQIP, has been associated with substantial improvements in both the quality and safety of VA surgical care, and was used as a template for the design of the American College of Surgeons NSQIP in the private sector. With Mission Act legislation facilitating non-VA surgical care for veterans, contemporaneous data regarding the outcomes of VA surgical care relative to the private sector would help both patients and policymakers ensure veterans receive optimal surgical care in the most appropriate setting. Thus, the objective of this study was to compare perioperative outcomes among veterans treated in VA hospitals to patients treated in private sector hospitals using VASQIP and NSQIP as comparable, high-quality, and audited national registries. This was a national cohort study of surgical procedures in VASQIP and NSQIP, non-cardiac surgical procedures in VASQIP and NSQIP, describing patients 18 or older undergoing a procedure between 2015 to 2018. The primary outcome was 30-day postoperative mortality. A secondary outcome was failure to rescue, defined as a postoperative death after a complication. Multivariable log binomial models were created to evaluate the association between surgical care setting and 30-day mortality. Robust standard errors were used to account for clustering within surgical specialties. Model covariates included frailty, physiologic stress of the operation, procedural urgency, and whether the patient experienced a postoperative complication. The Risk Analysis Index, or RAI, is a validated tool for measuring frailty in surgical and non-surgical populations and factors in more than simply age and comorbidities. The RAI is effectively a composite variable, including information about many of the clinical and demographic patient-level factors that would typically be included in a multivariable model. Similarly, the Operative Stress Score, or OSS, was used within the model to capture procedural factors. The OSS was developed using Delphi consensus methodology to rate the physiologic stress of surgical procedures according to a common scale, thereby permitting stratification across the diverse array of surgical procedures contained within VASQIP and NSQIP. Depicted here are examples from 3 specialties demonstrating how the OSS is structured to compare apples to apples. Sensitivity analyses were performed to evaluate the robustness of our study findings. We first added interaction terms to our models, and then looked at the results stratified by these groups to assess patterns of differences. We additionally evaluated the effect of adding years of covariate to address secular trends in quality improvement, included OSS as a 5-level covariate to adjust for procedure mix more granularly, and stratified by surgical specialty to ensure consistency in results across specialties. Also, a non-parsimonious model of patient-level factors, as described by Masarwe et al., rather than a composite variable of frailty, as measured by the RAI, was also evaluated. Finally, an e-value was calculated to identify the possible effect of unmeasured confounders. The cohort included over 3 million operations in NSQIP and 700,000 operations in VASQIP. Patients in VASQIP were older, predominantly male, and more frail than patients in NSQIP. The distribution of OSS was similar between the 2 registries, but NSQIP cases were frequently more emergent. Overall, unadjusted 30-day mortality, complications, and failure to rescue were significantly lower in NSQIP. However, relative to private sector surgical care, in our multivariable model, the adjusted risk of 30-day mortality was about 40% lower for VA surgical care. In sensitivity analyses, our findings were generally robust. VA surgical care was associated with a significantly lower risk of death among frail and very frail patients, however, was not among non-frail patients. But the interaction of surgical care setting with frailty on 30-day mortality was ultimately found to not be statistically significant. VA surgical care was also associated with a significantly lower risk of failure to rescue. and associated with a lower risk of mortality among those who underwent low physiologic stress operations, which accounts for more than 90% of those procedures in VASQUIP and NISQUIP. The interactions of surgical care setting with failure to rescue and operative stress were statistically significant. Further sensitivity analyses demonstrated similar relative risk reduction associated with VA surgical care when the model was run with years of covariate, as well as with the fully expanded OSS. The associated effect of VA surgical care was consistent across specialties, for instance, in the 3 largest specialties listed here. And in a non-parsimonious model, adjusting for patient-level factors rather than frailty, the adjusted relative risk of 30-day mortality was more than 50% lower for VA surgical care. Finally, we calculated e-values to quantify the effect of the possible effect of unmeasured confounders. If unmeasured confounding were present disproportionately in the NISQUIP population, the unmeasured confounder would require a relative risk of 2.78 to eliminate our main finding for 30-day mortality. There are several important limitations to consider when interpreting these results, but I will discuss 2 here. As with all observational studies, determining causation is not possible, and it's also possible that the observed association between better perioperative outcomes and surgical care at VA hospitals is due to unmeasured confounders. However, as I mentioned, it is unlikely that such unmeasured confounders would both A, would occur disproportionately in NISQUIP, and B, represent the relative risk of 2.78 needed to eliminate our main finding. Additionally, to ensure the greatest analytic parity, we excluded gynecologic procedures from this analysis, given the relatively few gynecologic procedures recorded in VASQUIP compared to NISQUIP. Additionally, veterans included in VASQUIP were predominantly male, and thus future work will be required to better characterize the quality of surgical care for women veterans in VHA. Nevertheless, over the past decade, major legislation has relaxed eligibility criteria for veterans to access non-urgent surgical care outside the VA, and more veteran health care has shifted into the private sector. Because surgical care is both high risk and costly, understanding the most appropriate surgical care setting for veterans is critical. In this context, our study supports 2 important conclusions. First, VA surgical care is associated with a lower risk of perioperative death, a finding that was robust to varying assumptions about the data. Second, this finding was consistent among patients who experienced complications, in other words, a lower failure to rescue in the VA. Taken together, this suggests VA hospitals may be best equipped to care for the unique perioperative needs and risk profiles of veterans. Our results may be explained in part by the specially tailored care processes VHA has developed over many years, ranging from intraoperative team training and clinical decision support systems, to mental health and addiction treatment, to transportation and lodging services. And these processes could be difficult to recapitulate in the private sector. Further, these processes become at risk within VHA should private sector diversion continue to reduce VHA utilization and, by extension, funding. These findings are relevant not only to individual veterans choosing between VA and private sector care, but also to the stakeholders making broader health policy decisions and budgetary appropriations. Future decisions should reflect these important differences in the quality and safety of surgical care. Thank you to all my co-authors, particularly my research mentor here at Stanford, Dr. Shipra Arya, and I'd be happy to take any questions.
Thank you, Dr. George. How do you think that the private sector could learn from the VA in terms of QI?
That's a great question, also a challenging one. I think the VA does a particularly good job of reacting almost in real time to the data that's recorded in VASQUIP. So their ongoing quality improvement and responding to the data in VASQUIP is almost in real time. And so using that data to actually enact change if they do identify a problem, their ability that has been shown to really act on that data is enviable. And I think the private sector is not unable to do that with their quality improvement programs.
Okay, and then another question from Slido is, was the NISQUIP cohort veterans getting non-VA surgical care, or is this all patients?
So that's a great question. Unfortunately, the true counterfactual of, for example, veterans getting care in the private sector as well as private sector patients getting care in the VA is not possible. So this was all patients getting care within NISQUIP, and then just studying veterans getting care within VASQUIP.
Okay. And can you control for the prevalence of emergency cases at VA hospitals versus the private sector failure to rescue may be more likely with a higher prevalence of emergency cases?
So the procedural urgency was included in our multivariable model as a covariate, so we did ultimately control for that. And while in including that, that still had a reduction of relative risk for mortality of about 40%.
Great. And then the last question is, did you do a stratified analysis restricted to elective procedures only? I just answered that.
That is an excellent sensitivity analysis. No, we did not actually do that, but I think that would be a great addition for the paper.
Okay, great. Thank you so much.
I'd like to thank the department for the opportunity to present our work. Today I'll be talking about the association between anemia and perioperative mortality for patients with heart failure. I received funding from an NIH T32 training grant. Heart failure patients undergoing elective surgery face an increased mortality risk compared to non-heart failure patients. The 90-day mortality risk for these patients is estimated at 5.5%, compared with 1.2% for their non-heart failure counterparts. Current efforts to optimize patients with heart failure ahead of surgery focus on risk evaluation by the medical team and optimization of heart failure-related medications. However, in a gap decomposition analysis, preoperative hematocrit was identified as the potentially modifiable risk factor most associated with the mortality gap. Approximately 1/3 of heart failure patients are anemic, and half of those have confirmed iron deficiency. In randomized control trials of non-heart failure patients, treatment of preoperative anemia with iron therapy has not been shown to improve outcomes. However, in heart failure patients, treatment of anemia has been associated with improved quality of life and functional capacity, decreased medical admissions, and decreased mortality. Therefore, we sought to better understand if heart failure patients undergoing elective surgery can be optimized ahead of surgery by treating preoperative anemia. Our hypothesis was that preoperative anemia would be associated with postoperative mortality in heart failure patients undergoing elective operations. To answer our question, we used the VASQUIP database combined with data from the VA CDW from years 2009 to 2016. We included patients with a confirmed diagnosis of heart failure, defined as at least one inpatient admission or 2 outpatient visits with heart failure as a primary diagnostic code within 3 years of surgery. We included only patients undergoing elective and standard and intermediate complexity operations, such as a lap chole or a total knee replacement. We excluded patients without 1 year of follow-up data and those who underwent a non-surgical procedure, excluded any patient with a missing pre-op hematocrit, patients categorized as an ASA5 at the time of surgery, or patients diagnosed with disseminated cancer at the time of the operation. Of approximately 600,000 patients initially isolated from the VASQUIP, about 48,000 of those had heart failure, and of those, 44,212 met our inclusion criteria. Anemia was prevalent in this population, as almost 63% of patients had a hematocrit below the lower limit of normal for men. 11% of patients had a hematocrit below 30%, corresponding roughly to having moderate or severe anemia. 90-day mortality increased as hematocrit decreased, with mortality rising significantly at hematocrits around 30. Based on this and an existing clinical definition of moderate anemia, which corresponds roughly to a hematocrit of 30, we stratified our further analysis based on whether a patient's pre-op hematocrit was less than or greater than 30. Again, in only heart failure patients, for the hematocrit group with hematocrits under 30, the median was 27.5, and for the hematocrit greater than or equal to 30 group, the median was 39.7. Overall, patients with lower hematocrits tended to have a higher rate of several comorbidities, such as diabetes and history of stroke, as well as worse preoperative renal function. In terms of their degree of heart failure, patients with anemia had slightly worse cardiac function based on preoperative echo data, though notably, in both groups, most patients had a preserved EF. In addition, patients in our low hematocrit group were more likely to be symptomatic from their heart failure. This corresponded to more patients with anemia being categorized as an ASA class 4 at the time of surgery. Anemic patients more frequently underwent standard complexity operations as compared to intermediate complexity operations and had lower rates of general anesthesia. However, they were much more likely to have an inpatient operation. Postoperatively, patients with anemia had a higher rate of complication at 30 days, at 21% as compared to 10% in non-anemic patients. This corresponded to a much higher 90-day mortality rate at 14.7% compared to 4%. Even after adjusting for available confounders, including medical comorbidities, age, and sex, as well as the operative complexity and the severity of reduced LV function, anemia was still associated with a markedly increased odds of mortality, and notably, an odds that was greater even than having a severely reduced ejection fraction. In summary, anemia is prevalent in heart failure patients undergoing elective surgery. These patients are generally sicker than non-anemic patients, but even after adjusting for all available confounders, anemia is still associated with a substantially increased odds of postoperative mortality in heart failure patients. Our study has several limitations. This is a retrospective study limited to the VA population. There are potentially other unmeasured confounders not captured in the data available to us. And we do not know what % of these patients have confirmed true iron deficiency, and also did not know if any of these patients were on iron therapy ahead of surgery. Finally, we excluded patients with missing hematocrits, though this was a small number of patients overall, and hematocrit was found to be missing at random. In conclusion, anemia is a modifiable risk factor associated with significant postoperative mortality. Anemia is treatable, especially iron deficiency anemia, which is common in this population. It remains unknown the extent to which treating anemia may mitigate the increased mortality faced by this population, and therefore we hope that future prospective studies can determine whether treatment with IV iron therapy can optimize these patients ahead of surgery. Thank you, and I'm happy to take any questions.
All right, very nice presentation. So if you could discuss, the PREVENT trial was recently published that showed no benefit to pre-op IV iron therapy. So with this in mind, how should we interpret your data and theory that treating iron deficiency anemia in heart failure patients might improve outcomes?
Yeah, for those not familiar, the PREVENT trial was a recently published randomized controlled trial of patients undergoing major abdominal surgery, randomized to IV iron therapy ahead of surgery, and there was found to be no significant benefit when looking at postoperative transfusions and mortality. I think the distinct thing is that that study had very few patients with heart failure in the single digits. And heart failure patients as a cohort in many other settings have been found to benefit from IV iron therapy. And so I think translating kind of a similar styled study to the PREVENT trial into this specific patient population may actually find that for them there is some benefit.
Okay. There's a question of, did you look at blood loss?
I haven't looked at blood loss yet, and we're in the process of combining that data as well as additional data from the CDW, looking at things like patients who did have iron study to sort of further determine patients' risks going into surgery and then their risks at the time of operation.
Also, a question of, did you look at transfusion or EPO treatment?
We haven't looked at EPO treatment. That's in that same data set that will hopefully give us better information about what types of therapy patients might have received ahead of surgery. And transfusion is also on our kind of next steps.
Okay, and then in discussion of your suggestion for a future study to look in this targeted population, would you be focusing on preoperative transfusions or IV iron therapies?
I think we'd be focusing on preoperative IV iron therapy. In these studies in heart failure patients outside of the setting of surgery, that's what's been done with proven benefit. And IV iron can be given in a single dose as an infusion ahead of surgery, with benefits seen in patients' hemoglobins within about 30 days of that infusion. So I think that's kind of a realistic option that avoids some of the risks of transfusion unnecessarily.
Okay, I think we have time for one more question.
Great presentation, interesting, and obviously a prevalent problem. We all see patients with anemia. I'm struck by the fact that there still could be a surrogate marker for sicker patients, even though you try to normalize for the covariates. There's still things there that aren't accounted for. It strikes me as the same thing as like low albumin predicts bad outcome, but you can't just give a person albumin and expect them to get better. So everything we do is a trade-off. So maybe you could talk about what you think iron is doing. Now, obviously, you'd say, well, iron is increasing the hematocrit. Increasing the hematocrit can increase oxygen delivery. You're going to deliver more oxygen to cells. Cells are going to be happier, but that's actually not the case. Your extraction ratio doesn't change very much, and the idea that you're delivering more oxygen to the mitochondria, it hasn't been proven with IV iron. And the second thing is that iron infusions have a downside to them. You can have a higher risk of infection because you're sort of loading the system, especially the reticuloendothelial system with iron, where, bugs are going to be taken up by the RES when the patient's operated on. So just maybe talk about what you think the mechanism is and what's the trade-off.
Yeah, that's quite a difficult question. Mechanistically, I do think it's notable that these heart failure patients seem to behave differently from other patients with anemia that are getting treated with iron therapy. And so I think translating some of the things we understand about the way iron therapy works globally for patients might be different for that heart failure population. And that might be one reason why in studies of heart failure patients alone, they actually do see some benefit outside of the setting of increased stress of surgery, even just in their day-to-day life. Mechanistically, I wonder if it's somewhat related to the underlying etiology of the iron deficiency and therefore a potential different response to receiving IV iron therapy, where for many of our other patients, there's some large component of anemia of chronic disease, potentially related to their underlying disease, where in heart failure, if there's a different underlying mechanism, the response to therapy is potentially different. The trade-offs, yeah, absolutely. IV iron therapy, I think one benefit, I guess, is you can give it quickly in a single dose. Trade-off to that is it's an infusion that's very costly, and many patients may not have access to that, and it's going to incur substantial costs for the system. In addition, you have to coordinate giving it ahead of time, et cetera, and so that also may not be feasible for all patients. One thing we were very intentional about is looking only at standard and intermediate complexity operations and trying to focus our further analysis on operations where you could very reasonably give a patient an infusion and wait for the necessary time, because that's another limitation. Some patients need to get to surgery more quickly.
Okay, I think that we will move on. Thank you very much.
Hello, everyone. Thank you for this opportunity to present our work on insurance instability after traumatic injury. So here's my agenda for my presentation, moving right into the introduction. As many of you know from firsthand experience through your clinical practice or your training, trauma can be incredibly debilitating. In the US, it is the leading cause of mortality for adults under 44, and globally it ties with ischemic heart disease as the #1 contributor to disability-adjusted life years. And many patients do report problems with returning to work after a traumatic injury. A 2002 multi-center study in the US found that only 30 to 44% of trauma patients were able to return to work after 3 months. In a Dutch study, trauma patients cited problems with pain, anxiety, and depression, mobility, self-care, and cognitive function as reasons why they were unable to return to work. This, in turn, may lead to issues with maintaining health insurance, especially in the United States, where 58% of working-age adults are actually covered from their employers. And in fact, many trauma patients do report changes in their insurance status after a traumatic injury. A paper actually from Dr. Rajasingh found that 19% of trauma patients who were readmitted within 6 months experienced a change in their insurance status. Of these, 21% lost insurance, 52% switched insurance, and the remainder gained. And several studies have shown that not having insurance is a major risk factor for worse outcomes in trauma patients, including higher risk of mortality and disability. And so therefore, we propose the following framework to think about insurance and injury. So a traumatic injury leading to a disability that then impedes the ability to return to work may lead to a disruption in health coverage from an employer. We can also imagine another arrow going from insurance loss to disability, as lack of insurance is a barrier to accessing long-term care, such as rehabilitation, home health, which in turn may prolong recovery and just worsen this cycle. So we hypothesize that an increasing injury severity would be associated with a higher risk of insurance loss in patients with private insurance. So to test this hypothesis, we performed a retrospective cohort study using Optum Clinformatics Data Mart. Optum is an insurance claims database with claims from over 62 million beneficiaries from 2003 to 2020. We started with patients with any trauma diagnosis and then applied the following selection criteria, including adult patients under the age of 61. We also kept the study focused on traumatic encounters that were evaluated in an acute hospital setting, so meaning either the emergency department or hospital admission. Our primary outcome was the time to insurance churn, which we defined as cessation of enrollment in the Optum database within 3 years after their trauma. We tracked several patient and injury encounter variables, including injury severity. We categorized injury severity as mild, moderate, severe, and profound using the injury severity score. We then performed a time to event analysis using Kaplan-Meier survival curves and the Cox proportional hazards regression. So ultimately, we included 750,862 patients who met selection criteria. Our cohort was slightly more male, median age of 40 years, were predominantly non-Hispanic white. Patients were generally healthy at baseline, and most patients suffered a mild injury. 74% of our cohort were seen and released from the emergency department, and the remaining 26% were admitted. Overall, 73% of our patients experienced insurance churn. Those who experienced churn were younger and more likely non-white. And of the patients who churned, 18% eventually returned to an Optum plan at an average of 19.1 months. So here is the Kaplan-Meier survival curve for mildly injured patients. Their median time to churn was 7.7 months. Next, we have the moderately injured patients who churned at 7.5 months, and then followed closely by severely injured patients. And then finally, we have profoundly injured patients who churned the fastest at 7.1 months. In our Cox proportional hazards regression, the model outputs hazard ratios, which tell us the likelihood of an event occurring in a test group relative to a reference group at any given time during the study period. We used mildly injured patients as the reference group. So that means that in comparison to mildly injured patients, moderately injured patients were 8% more likely to churn at any time compared to mildly injured patients. Severely injured patients were 10% more likely, and profoundly injured patients were 19% more likely. So we do see a greater chance of insurance churn as injury severity increases. So to recap, 73% of trauma survivors with private insurance experienced insurance churn within 3 years after an average of 7.7 months. Going back to our hypothesis, we did then find increasing injury severity was associated with a greater chance of losing insurance. Our findings are in line with previous work on TBI and spine injuries. A prior study actually from a Stanford surgery resident or graduate, Dr. Kastenberg, found that spinal trauma patients were twice as likely as a matched cohort to drop insurance, and those with spinal cord injuries are nearly 3 times as likely. Insurance churn in the US has been a problem for decades, given the patchwork coverage system that we have. However, the ACA, the Affordable Care Act of 2010, did see some improvement in insurance churn in the fact that fewer patients reported losing insurance after job loss, and that the duration of being uninsured was shorter. However, despite these improvements, insurance churn remains a problem. Patients who particularly for vulnerable populations, including minorities, the poor, and those with chronic medical conditions. In fact, patients who switch in and out of Medicaid frequently report issues with finding and maintaining primary care doctors, with making appointments, with refilling and taking medications, and they use the emergency department more often. So our greatest limitation in our study was the fact that we were confined to a single insurer, which meant that we were unable to track patients' movements once they left Optum. So for those 18% of patients who churned and eventually returned to Optum, we don't know what coverage they had while they were out of Optum. The fact that they returned after an average of 19.1 months may reflect that this is when they were able to return to work. However, if that's the case, this still suggests that these patients were unable to work for more than, on average, 1.5 years after their injury. We did benefit from the size of the Optum data set and the fact that it did allow us to track patients' movements both back into Optum and within Optum. Moving forward, there are several additional analyses that we would like to perform. For one, The association that we did find between injury severity and rates of churn were smaller than we had expected. This may reflect the fact that most of our cohort was actually seen and released from the emergency department. So we'd like to do a secondary analysis on just hospitalized patients. By focusing on those who are admitted, we may see more dramatic relationships. Next, we'd also like to explore different anatomic injuries or injury patterns. I think we often most think of head trauma, spinal cord injuries when we think of long-term disability, but there are several other injury patterns like limb loss or severe thoracoabdominal injuries, rib fractures that could also lead to disability and a long time to recovery. And finally, we'd like to extend this analysis to other adverse health shocks that may impede the ability to work, including cancer. There have been some studies that show that cancer patients face higher risk of periods of uninsurance than non-cancer patients, and those with unstable insurance are more likely to delay treatment and be lost to follow-up. So that is the end of my prepared remarks. Thank you so much for your attention, and I'm happy to take questions.
Very nice, thank you. What do you think is the effect of high deductible health plan status on insurance churn?
Yeah, absolutely. So to back up a step, a high deductible health plan is one where patients carry more of the cost-sharing burden if they do seek medical care. So maybe compared to a traditional plan where you're paying $300 a month in deductibles, but if you do go to the hospital or see a doctor, your deductible is maybe only $1,000. But in a high deductible plan, much like the name, you have a high deductible, maybe up to $5,000 in a year, but you pay a much lower premium. And so the patients who do enroll in a high deductible plan tend to be younger, healthier, and wealthier actually at baseline. So actually we found that in the churn group versus the non-churn group, there's a slightly higher prevalence of patients with a high deductible plan. But in our multivariable regression, we actually found that having a high deductible plan reduced your chance of churn by almost 50%. So that may reflect the fact that the high deductible patients are this healthier, wealthier, younger group. So I think that would be an interesting area to explore.
Great, thank you. And did you do a pre and post ACA analysis? And if so, what did you observe?
We did not. We do have the data for that because it does span, our selection period was from 2007 to 2017. Now, given that this is a private insurance network, we don't expect to see much change even with the ACA. That is, I think, one of the issues with the Abdomen database is that we don't have access. We don't know if patients switch to Medicaid, for example. But Dr. Rajasingh's paper actually did find that patients, when they gained insurance, they tended to gain Medicaid. So I think that definitely plays a part in the whole picture of insurance coverage.
Okay. And you said that in your next steps you want to look at anatomic areas, but did you see any specific injury patterns, or have you not looked at it at all?
We have not yet begun that. Okay. But yes, we'd be interested to see, what injury patterns pop up as being more severe.
I think we have time for another question. Thank you.
Great job. I'm just very impressed by your fluency in this topic because it's complicated. And so congratulations on an interesting area of research and something that's important. So it strikes me that there needs to be some policy change around this. Let's imagine for a moment that, you're a senator or a congresswoman and you could make a policy change. What would that be?
It would be universal health care, but I think that is the pipe shot. That's the moonshot, exactly. So yes, but I think, it's going to, after having studied about this and learning about this, I realize more and more that that's incredibly difficult to accomplish in this country. But I truly don't think that there are any other policies that will ever come close to that. You can try with stopgaps, mandatory coverage requirements, things like that. But as we've seen in certain states, for example, Arkansas in 2018 passed a work requirement for Medicaid. So now you have to even demonstrate that you have a job just to get Medicaid, which again completely defeats the purpose. So I think there truly has to be movement on a national level to make this happen. Yeah.
Thank you.
Thank you.
Good afternoon. My name is Calvin Perumalla, and I work as a postdoctoral researcher at the Techie Center here at Stanford under the leadership of Dr. Carla Pugh. One of the research goals of our lab is to quantify and improve surgeon skill. So today I'm going to talk about the use of a simulator and a multimodal method of assessment that could potentially improve how we do skill assessment and training. So the goal of surgical training, as we know, is to produce competent and safe surgeons. And certifying exams assess competence as a written and oral exam and assume technical operative competence. Although the idea of testing competence in the operating setting is attractive, is currently met by a challenge, which is the current system doesn't have the methodology to properly quantify the cognitive and technical skill of the surgeon. So to that end, the goal of a pilot study that we did was to test a methodology to perform multimodal evaluation of basic cardiac skills within a high-fidelity simulation environment. The simulator we use contains a porcine heart inside a silicone pericardial well, and it is perfused with blood substitute, and it's connected to a pneumatic driver, which allows it to beat. A console and monitor are attached to display key vitals. The simulator is made by Kind Heart Technology and was provided by the PI of this work, Dr. Joshua Hermsen from the University of Wisconsin. So the participants were asked to perform 3 tasks. In the first task and the second task, they were asked to perform a basic aortic cannulation and decannulation. And as a part of the third task, they were asked to do the aortic cannulation and decannulation, and in addition to that, they were asked to initiate cardiopulmonary bypass and arrest the heart by applying an aortic cross clamp. So there were a total of 6 participants, 3 attending surgeons and 3 fellows. We also had an assistant who assisted in all the procedures. Electromagnetic sensors were attached to the hands of the surgeon and the assistant so that we can track their movement during the procedure. Certain metrics were derived from these readings, such as, and these readings we hoped would differentiate skill between the experts and the trainees. So some of the metrics that we derived were path length, which tracks the total distance moved by the hands of the surgeon. Idle time, which tracks the total idle time of the surgeon while they're performing the procedure. The bimanual dexterity, which shows how well the surgeons move both of their hands together. And smoothness, which tracks how smooth their hand movements are. Checklists were also used to evaluate the technical and cognitive aspects of the surgeon's skill. The checklist checked performance across 20 cognitive domains. The procedure was rated real-time by a non-participating attending surgeon. Here are some examples of the cognitive skills that were part of the checklist. For example, it was checked if a clear command to initiate cardiopulmonary bypass was given to the assistant. Again, the checklist also checked skills across 21 technical domains. For example, it was checked if the surgeon needed to reset the needle manually when placing a purse string suture. And each participant was scored based on this checklist. And this checklist was provided to us by our PI, who was a cardiothoracic surgeon from the University of Wisconsin. So here are some of the results we saw with the scores. The first result we observed was with the aortic cannulation and decannulation. Note that each participant had to do 3 aortic cannulations and decannulations, and the data you see here reflects that. So we saw that experts scored significantly higher in the cognitive score than trainees, but this trend was not observed in the technical scores. And in fact, this trend continued, and even when we considered the total procedure as a whole, we saw that cognitive scores were significantly higher for experts than they were for trainees. Coming to the motion-related metrics, we saw that the path length was significantly lower for experts during the application of the cross clamp than it was for trainees. And we also saw that the percentage of simultaneous hand movement between the surgeon and the assistant was significantly lower for experts than it was for trainees. So that means when the assistant moved their hands, the surgeon's hands were moving less, or rather the expert surgeon's hands were moving less. So in conclusion, apart from these 2 instances, we did not find significance for other motion-related metrics for this pilot. However, we saw a level of differentiation that shows motivation for a future larger study. The percentage of simultaneous movements of surgeons and assistants was significant. We think that one of the reasons that this could be is because experts are more clear and detailed in their instructions to their assistant. The results show that a multimodal system of evaluation shows some promise. It'll be interesting to see the results of this study as a part of a larger study. It is very promising that experts and trainees can be discerned on the basis of cognitive skills, even in a simulated environment. And we believe that one of the reasons that this is the case is because trainees have reached a level of unconscious competence in their work owing to the multiple years of practice that they've had. And thank you, and I'll take some questions.
This is excellent work, which provides strong validity evidence for this assessment's ability to distinguish between fellows and practicing surgeons with regards to efficiency and cognitive skills. How can you expand upon your preliminary findings in the study and how this model might be used to enhance surgical training?
Sure, thank you. That's a great question. Like I said, one of the limitations of this study is the fact that the number of participants are low. So we definitely love to see more participants take part in this study, and we would also want to see more diversity. One of the things I didn't mention was all the participants were right-handed and male. We would like to see more diversity as part of the study as well. So those are two things that, and also we would love to see the simulator used as a part of other procedures as well. So.
Okay, and then do you envision this moving forward as being more of a formative assessment as a training simulator or more as an assessment platform for competency?
Sure, I think definitely as a start it could be used for a formative assessment and something that could aid in training. Yeah, and in the future maybe it could also take on the role of a summative assessment.
Okay. So you mentioned that the cognitive, so essentially, what is the reason that the cognitive portion of the procedure significantly varies between novice and expert? And then the converse of why do you think you did not see a difference in the technical scores? Do you think that that's an issue of sample size?
Yes, I think definitely sample size has one thing to do with it. And to answer your first question, like I was mentioning, I think one of the reasons is because of the automaticity that expert surgeons gain over years of practice that allows them to be very clear and structured in their communication to the assistant. And yeah, and that's the reason why I think their cognitive scores are higher than trainees.
Okay. And then you mentioned competency threshold. So if you could elaborate more on planned next steps if you were to design a future study of how these benchmarks could play a role perhaps in surgical entrustment or autonomy decisions with trainees.
Yeah, like I said, and the first thing to do would be to plan a larger study with more diversity and kind of look at these metrics across these different stratifications and kind of make a decision on, or an educated decision on what these thresholds should be. But I think it does hold a promise.
Good, and we have time for another question.
I don't know much about this except to say that it's promising. Our trainees want to get to mastery sooner. So the real deliverable here is not to distinguish or discriminate between who's good and who's bad, who's senior, who's a trainee. Right. That's important. That's the baseline. But it's to drive mastery to a shorter time period, because now it takes, I don't know what, 10, 15 years to become a master at the operations that you do. So how do you envision training to higher levels of competency that would occur from the simulation different from then just practicing for 20 years?
Right. Yeah, I think that's a great question, and it's a question that we've asked ourselves at our lab and we are currently thinking about. And I think some of what I spoke in the talk covers that about using a simulation. So the goal here, again, is, like you pointed out, it's more than just seeing if someone's right or wrong. It's to get people to a mastery much quicker, get trainees to a mastery much quicker. And I think the answer lies in developing these metrics, these motion-related metrics, using these different kind of multimodal sensors that could give you a granular view of what the trainee is doing, and kind of analyze that data and come up with metrics that can benchmark trainees and make sure that they hit those benchmarks. But yeah, that's definitely a question that I think we should try and answer. Thank you.
Okay, thank you very much.
Good afternoon. Thank you for the privilege of the podium. I have no relevant conflicts of interest. Endovascular aortic repair is the dominant modality for treating abdominal aortic aneurysms, having outpaced open repair in the early 2000s. This is in part due to increasingly available technologies and randomized data demonstrating an early short-term survival and morbidity benefit in these patients. On the contrast, however, EVAR is less durable, with higher reintervention rates up to 15 years of follow-up. Ultimately, this is why postoperative imaging surveillance is necessary to monitor and intervene on potential complications to avoid late rupture. However, the optimal imaging modality for surveillance has not been established. This is a practice gap worth addressing because of the wide range in cost, diagnostic utility, and risk conferred by the available imaging modalities. Every surgeon would love to perform annual CT angiograms on each patient, but ultimately this comes at high cost and a risk of contrast-induced nephropathy. Color duplex ultrasound is safer and cheaper, but has reduced sensitivity and specificity, the quality of which is also modified by patient habitus. Contrast-enhanced ultrasound is an emerging modality in the United States wherein a renal-safe contrast is injected to the patient during scan. This helps distinguish the graft from the sealed aorta, as you can see in this cross-section. It also has improved sensitivity in CDU, but diagnostic uptake in the US is still relatively low. National guidelines from the Society for Vascular Surgery recommend that patients without 1-month complications on CT scan can be surveyed annually with CT or ultrasound, but does not state a preference for either. Thus, our goal was to identify a cost-effective surveillance strategy after EVAR out of 5 options based on current practice patterns. Our available strategies included an annual CTA, an annual duplex ultrasound, an annual contrast-enhanced ultrasound, then hybrid strategies in which a CTA was performed in the first year, followed by yearly ultrasound thereafter. Our analysis was driven by a decision tree with nested Markov models run on the baseline characteristics of a 74-year-old male over a time horizon of 30 years. Every month, we recalculated the status of our cohort and applied utility in the form of quality-adjusted life years, or QALYs. The typical annual discounting rate of 3% was applied, which prioritizes early utility benefits, and our willingness to pay threshold was $50,000, which is classical for United States-based studies. I'll start by introducing our Markov model, which might look a little hairy initially, but can be parsed through by thinking about a couple scenarios. The model simulates 8 states that a patient can experience with varying probability of transitioning between states every month. All patients begin on the no complication state on the left, and the bracket on the right indicates that any patient in the pastel state can migrate to the red death state. The 6 other states in the middle are categorized along 2 axes. First, whether the complication was severe, and second, whether the complication was detected, undetected, or falsely detected. So let's walk through an example. We can understand our transitions to the Markov model by considering a best-case scenario. A patient who undergoes EVAR has a benign CT scan at 1 month and survives to their 1-year follow-up. In this arm of the decision tree, they're assigned to a yearly CTA strategy. The decision tree allows for 4 outcomes based on the sensitivity and specificity of the scan: true positive, true negative, false negative, so on. To walk through the model, in our best case scenario, let's say the patient has a CT scan that shows a true positive result, meaning that a complication was accurately detected. They can move into one of 2 potential Markov states depending on this type of complication. More severe ones require surgery, whereas less severe ones will only require additional surveillance with a CT scan. In this case, the patient has a severe complication and surgery is recommended. There are 3 possible outcomes from the surgery: mortality, although rare, failure of surgery to resolve the complication, and success. Our best scenario case patient then has a resolved complication and enters a high surveillance state. Variations of this walkthrough can happen for each of the 4 scan results, and we can also envision them through the Markov visualization. Assuming a potential worst case scenario this time, the patient begins our model in the no complication state. Let's suppose their yearly scan results in a false positive, leading them to move into an unnecessary surveillance state where they don't have a problem, but get scanned as if they do. In another bad round of luck, they have another false positive scan and are thus recommended to undergo surgery. And in the worst of worst luck, they actually suffer a perioperative mortality. Between the best case and the worst case scenarios described is a gradation which is represented by the various other arrows in our model. To model the likelihood of transition between all 8 of these states, we derived EVAR-related estimates from the 15-year outcomes of the EVAR-1 RCT and baseline mortality rates from the National Vital Statistic reports. Parameters such as sensitivity and specificity were retrieved from systematic review and meta-analyses. Imaging costs were derived from the Medicare fee schedule and adjusted for inflation. Our results demonstrate the accumulated costs and qualities incurred by each strategy when the model ran its course. Out of the 5, CDU offered the lowest cost, while the hybrid CTA-CDU strategy offered the highest qualities. The incremental cost ratio, or ICER, suggested that for the cost of $3,100 extra per quality, we could obtain superior utility with the hybrid approach. Thus, at a willingness to pay threshold of $50,000, CTA-CDU was the most cost-effective strategy. We proceeded with sensitivity analyses to test how robust our model was to several underlying assumptions in the base case. First, we varied the sensitivities of CDU and CEU, given that the diagnostic utility of ultrasound varies based on patient habitus and can also happen due to sonographer experience. We found that the CT-only strategy only maximizes qualities when CEU sensitivity is below 75% and CDU sensitivity is below 55%. Since most literature estimates are much higher than this, it suggests that the recommendation for including ultrasound in EVAR surveillance is rather robust. In another sensitivity analysis, we evaluated the effect of varying specificity of CTA with the risk of renal injury after contrast administration. As many of us know, vasculopaths have a high risk of chronic renal disease, so surgeons routinely have to adjudicate how to implement this comorbidity into the surveillance categories. We found that CTA specificity is greater than 85%, which is rather reasonable based on the literature. A CTA-CDU strategy was cost-effective up to a 20% risk of renal injury. After that, the model preferred a CDU-only strategy. In conclusion, a hybrid strategy in which CT angiogram is performed in the first year after EVAR, followed by duplex ultrasound, is cost-effective for EVAR surveillance up to a 20% risk of post-CT acute kidney injury, after which only a duplex-only strategy is preferred. If the sensitivity of enhanced ultrasound and duplex ultrasound are at the lower end of plausible estimates, it is reasonable for an institution to pursue yearly CT scans. Limitations include emerging data on the sensitivity and specificity of the CEU in the United States, and that our transition probabilities are based on randomized controlled studies for long-term follow-up, but may not reflect the most recent technologies and techniques. Costs were also limited to the healthcare perspective. Our future work is in incorporating societal cost perspectives, modifying transition probabilities to reflect real-life data, and adapting our model to complex endovascular aortic repair patients. This work was born out of an excellent class taught by my mentors, Dr. Doug Owens and Josh Solomon, and the result of some very talented classmates in health policy and management science. My part is funded by the Stanford Intermountain Fellowship. Thank you very much.
Thank you, Dr. Ho. How do you account for variable types of data like RCTs, retrospective, industry-sponsored data into a cost model? And do you think that having more data sets is necessarily a good thing for these types of analyses?
It's a great question. It kind of varies based on the kind of data you're looking for. So when you're looking at outcomes, I think RCT is the gold standard because you're dealing with much more controlled populations. You are unfortunately trading off some realism in the sense that the patients from the longest running RCT are getting the oldest devices. They were chosen anatomically to kind of be the best candidates, which isn't the same thing as real world practice. So I think what you're speaking to is the need for a blended strategy. So I think for outcomes itself, it's the gold standard is to use the RCT for cost effectiveness analyses. But when you're looking at the incidence of complications and how that affects the model, particularly in the sensitivity analyses we're talking about, I think it's important to take that data from more contemporary sources because ultimately you're trying to inform the surgeons of today and not the folks who performed the randomized trial 15 years ago.
Great. Why do you use such a long time horizon?
Oh, so the time horizon in this case, whoever pointed that out is very astute. It's almost unneeded because we basically ran the model until all patients passed. either of surgical complications or of natural causes. And so the time horizon is something we specify as kind of a pro forma aspect of doing the cost effectiveness analysis, but because our patient population is on the older side, we pretty much ran it till completion for all patients.
Okay. And the final question is, would the CTA-CDU strategy change based on the size of the aneurysm that requires surveillance?
Oh, that's an interesting question. So I would actually say that usually surveillance is not necessarily driven by the size of the aneurysm after sealing anyway, because theoretically you've depressurized the sac and the relationship between aneurysm sac diameter and rupture no longer exists. So I would actually say that the more relevant clinical question in surveillance is actually efficacy of the stent. So do you have a type 2 endoleak that you're watching? Does that make you want to do an extra scan in 6 months? Or is this also, let's say, a higher risk patient with poor access to care? Do you want to kind of keep them in the system? I think those are the kind of questions that we sought to answer in our sensitivity analyses to provide insight to practicing surgeons. But as far as the underlying diameter, that's something very interesting to explore, but also something that kind of makes me want to go back and get a sense from other surgeons, like how much does that affect your algorithm?
Thank you.
Thank you very much.
Dr. Alberti, one more question.
Oh, yes, please.
Sorry, fantastic presentation, and I just love the quality of the science here. So it strikes me that we're learning how to frame the contingencies that face us when we take care of patients in the Markov model, and then how we then manage uncertainty. And how do you envision this happening with machine learning in the EMR? In other words, you did all this. What if the EMR did it automatically and we went in there and, maybe your work will inform how that computing is structured and simulated. But at some point, you're going to go into the EMR, it's going to say, you need an ultrasound at 4 months because of all this stuff and all the aggregated data. Is that correct?
I just love that you asked that question, because I'm in my first year of my informatics master's, and this is like the meat of what I love to do. So ultimately, models can provide an incredible amount of computing power. They can highlight correlations that we didn't know exist. But the model on its own cannot provide clinical context, and it cannot understand how its output actually affects a physician decision. So I think, in the last 10 years, it's been a beautiful whirlwind. Anyone can predict something now. If you have the computing power and you have the packages in Python, you can predict something. The question is how to predict something that moves the needle toward better care. And that, I think, ultimately, for example, in this case, you can say, okay, the most cost-effective thing would be to get the duplex ultrasound. But if you're the surgeon sitting in the seat and you say, actually, the model doesn't take into account some aspects of my patient. I'm concerned that they might have a history, their father died of an aortic aneurysm. I want them screened for a genetic condition. I'm actually going to bring them back a little sooner, get a more detailed scan. Those are the kind of things that I don't want machine learning to lock decision makers into. I want it to be an asset. So I think there's still a lot more. I could talk about that for an hour. But I think there's a lot more, that we have to do before artificial intelligence truly assists us where we're at. But that's kind of the gap. Thank you.
Thank you.
Good afternoon again. As a part of my second talk, I'm going to be talking about our work, which relates to how artificial intelligence can be used to surgical videos. I'm presenting this work as on behalf of my colleague, Dr. Hossein Mohamadipanah. So we live in an era of minimally invasive surgery where cameras are used in the OR to assist in procedures like laparoscopic surgeries and robotic surgeries. And the feed from these cameras are saved as videos and can be reviewed later, and surgeons are free to review them and learn from them. One particular use case is the remote and asynchronous rating of surgeon skill through video review. So that means raters can watch these videos from a different location and a different time and rate the skill of the surgeon performing the procedure. However, one of the limitations of this procedure is the fact that raters may be interested in only a handful of critical events in the procedure. And this means that raters have to scrub through the entire video and find these events. And this can definitely take a long time and add to the workload of the surgeon. So one potential solution to this problem is centered around the use of artificial intelligence. AI algorithms can be trained to identify interesting portions of the video and segment them for ease of review. In our work, we develop an artificial intelligence model to detect the injury identification phase and the suture repair phase of a procedure. We also develop an AI model to identify objects in the video, such as tools and tissues, to see if the visualization strategy used by the surgeon is significant to outcomes. So the data for this work comes from a data collection study that we at the Techie Center did at the 2019 American College of Surgery conference in San Francisco. 200 surgical videos were used in this analysis. There were 10 stations present, and tools and assistants were provided. Each participant was asked to perform an enterotomy on a small piece of porcine bowel. Each surgeon was outfitted with multiple sensors, such as motion tracking sensors on their hands and EEG tracking sensors on their heads, and 2 cameras were used to capture the full procedure. The porcine bowel had 2 injuries, one small and one large, and participants were asked to identify any holes, and this was called the injury identification or the visualization phase of the procedure. They could then proceed to repair them, and this was called the suture repair phase of the procedure. In the end, a leak test was performed by filling the bowel with liquid and testing if there were any leaks. So the first analysis we did was in building a model to detect these 2 phases. First, we split each video into 2-second clips, and then we feed it into a convolutional neural network, or a CNN. Now, CNNs are AI algorithms specialized to deal with images and video frames. And then we feed this information into a gated recurrent unit, or a GRU, and GRUs specialize in capturing temporal dependencies or temporal aspects of the information. Finally, the model was able to use this information to make a decision about whether the clip belonged to the visualization phase or the suture repair phase. The algorithm has to be first trained and validated with 80% of our videos, and then 20% was used to test and evaluate the model. So the model was able to have an 86% precision in detecting the injury identification phase and a recall of 81%. So what this means is that the algorithm was correct 86% of the time when it thought a clip was related to injury identification, and was able to correctly detect the injury identification clips 81% of the time. And the last 3 columns here show the number of samples required for training, validation, and testing. So that was related to the detection of the 2 phases, the visualization phase and the suture repair phase. Another application of AI is to perform object detection and localization. We particularly use it in our work to detect the tools, tissues, and hands in the frames. One reason to do this is to answer the question of whether the use of certain strategies in the visualization phase are more efficient than others. For example, if the strategies some of the strategies that surgeons use is using hands to run the bowel, or using a combination of hands and tools, or just tools to run the bowel. If we were to do this manually, this would take a long time, since we would need to watch all the videos and check what strategy is being used. But with the use of AI, this process becomes much faster. In order to identify the objects we use, in order to identify these objects, we use an AI algorithm called YOLO, which stands for You Only Look Once. So we take each frame of the video, and we feed it into a fully trained YOLO algorithm, and then the algorithm identifies each of the objects that are inside the frame and puts bounding boxes around them. So given these annotations, it is easy to know which strategies the surgeon is going to use to run is using to run the bowel. And this here we briefly discuss how the object detection algorithm is trained to identify these classes. First, 856 frames from the videos are annotated by humans, which means tools, hands, and tissues are identified in the frame, and bounding boxes are placed around them. 600 of these are used to train the model, and 256 are used to test the model. Using precision as a metric, we see that the algorithm performed really well in identifying the hands, tissues, and tools. we achieved close to 97% of mean average precision over all these classes. In terms of the analysis of the significance of visualization strategy and efficiency, we saw that the 3 strategies were not significant with respect to the time taken by the surgeons to identify the injuries. We also found that the strategy used to run the bowel did not have a big impact on the outcomes, that is, missing or not missing a hole. Lastly, we found that the strategy was not found to be significant across age or handedness or surgical specialty. In conclusion, we built a model and achieved a high performance in detecting the injury identification phase, the suture repair, and the suture repair phase. We achieved a high performance in identifying and localizing hands, tools, and tissues. And we've shown a proof of concept that AI can be used efficiently to process videos in a way that will decrease the workload of reviewers in the future. Thank you. I'm happy to take some questions and comments.
All right, thank you. This is very exciting work. So how do you envision or see the role of artificial intelligence as an effective use of surgical videos to improve the surgical education of our trainees?
Yeah, thank you. Yeah, I think this is, like I said, this is just a proof of concept of what can be achieved with artificial intelligence. I mean, there are other applications such as using artificial intelligence to generate reports on certain aspects of the skill and ideas around how we can use artificial intelligence to do the rating by itself. And so those are all interesting ideas, I think, that can be pursued. For example, some of the data that we collected shows that interrupted sutures and running sutures are can lead to different outcomes, and building models that can identify these preliminary pieces that can then be put together to build a model that can do rating and give feedback reports to the surgeon would be very useful.
Okay, and I'm curious, how easily transferable is this to laparoscopic or robotic videos? You'd mentioned that those videos are easily available. Yes. How much additional work does it require to translate what your findings here to a laparoscopic procedure?
Yeah, that's a great question. And I think, so these models were built on a much smaller data set. In theory, there are a lot more laparoscopic videos out there, and you would use those videos to train a model separately. But if we were to do it this way and use this model, you would need to train this model against maybe a moderate-sized data set that we annotated. And yeah, that could be a function of how long it takes to annotate these videos, which is a long time. But the good news is that we can actually build custom-made solutions for each problem, and we can actually there's evidence to show that those models actually generalize well to larger problems, and so yeah.
Great. There's a question from the audience. Any other CNN models ran on this data and compared to the baseline? Curious how other processing techniques tackled this data.
Yeah, I mean. Yeah, so the CNN algorithm that we used here was called MobileNet V2, and there were many other algorithms that were tried out, and this one actually showed the best results. Yeah, like I said before, this algorithm was pre-trained. We're using a off-the-shelf model that could generalize well. But if you were to use, I think the first thing that we tried was what you call from the scratch CNN algorithm, which takes a much longer time to train. Yeah, and I believe there are other methods that you could use for pre-processing as well. Yeah, definitely you could try and feed the frames directly to the GRU, for example, and things like that. But what you get from the CNNs, and particularly this one, is it's easy to train because it's pre-trained. And number two, you are able to capitalize on the visual information from each of these videos, right? Like, okay, so the model at some level understands, okay, wait, so in the visualization phase, there's a lot of touching the tissue, for example. And so that information is gathered by the CNN, and then the GRU processes that information.
Okay, and one last question from the audience. What tools or add-ons would improve precision if this was used for pass-fail or credentialing applications in the real world?
Yeah, that's a great question. I'm not sure if I've thought about that or have a clear answer on that, but yeah, I mean, definitely, I see this, before we start using this on a larger set, it has to be trained on more data. This is 200 videos and a very simulated procedure. So before we start using this at a higher level, I do see basically retraining this on a lot more data. This is basically a proof of concept that you can do something like this. The way you would go forward is get more data and more people involved in annotating this data and then train a bigger model.
Okay, thank you very much.
Good afternoon, everyone. I'd like to thank the Research Oversight Committee for the opportunity to present today. I'm Kirbi Yelorda, and for the next 8 minutes or so, we'll be talking about the impact of high-deductible health plans on hernia presentation. So this year, the IRS defined a high-deductible health plan as an annual deductible of $1,400 for individuals or $2,800 for families. These plans are appealing to many because they usually have lower premiums, and they can often be coupled with tax-free savings accounts. However, they present two major problems. First, they're associated with higher out-of-pocket costs, particularly for patients with chronic medical conditions. And secondly, there's been evidence for delay in seeking care and even decreased healthcare utilization for patients enrolled in HDHPs. We've seen this with macrovascular complications of diabetes, bariatric surgery utilization, and breast cancer diagnosis and treatment. So the purpose of this slide is to illustrate that more and more people are enrolling in high-deductible health plans, over 50% of employees in both small and large firms as of 2019. So given the potential delay or foregone care and the increasing number of patients enrolled in HDHPs, I therefore ask the questions, are patients in high-deductible health plans more likely to present with a complicated hernia, which could be associated with delay in seeking care? My hypothesis was that they are, and that they present to the hospital with these complicated hernias more often than those in low-deductible plans, potentially to avoid high out-of-pocket costs. As a secondary analysis, I investigated if there's a positive relationship between deductible amount and the odds of presenting with a complicated hernia. And to do this, I used Optum, which is a nationally representative private claims database. So a couple of important definitions that we'll need to go over. I use the IRS definition for a high deductible health plan. So if someone's yearly deductible was greater than or equal to $1,300 for an individual or $2,600 for a family, and their index operation was in 2016 or 2017, I place them in the high deductible group. Similarly, if someone's yearly deductible was $1,350 for an individual or $2,700 for a family, and their index operation was in 2018 or 2019, I also put them in the high deductible group. Other important definitions, a complicated hernia is one that's resulted in bowel obstruction or strangulation. This is usually a surgical emergency. An uncomplicated hernia is one that has neither of those things, and these are usually repaired electively. So my patient population was commercially insured patients between the ages of 18 to 63. I looked for patients who underwent a femoral, inguinal, or ventral hernia operation between January 2016 and June 2019. That's the most recent Optum data that we had at the time. And I chose to start at 2016 because that's when we use ICD-10 codes, which are more specific than ICD-9. And this is just a list of the CPT codes that I used to isolate these patients. So first, I ensured that the smallest cost was at least $1,300, making it unlikely that someone would have a hernia operation and not meet their deductible for the year. This is important since I place patients in high deductible and low deductible groups based on their paid deductible amount for the year of their index operation. So for patients in family coverage, I identified family members using a unique family ID and summed all family deductible amounts to find the family deductible for the year of the index operation. I then dichotomized them into high and low deductible groups based on which side of the IRS cutoff their family deductible fell on. Similarly, if patients were enrolled in individual coverage, I totaled their deductible amount for the year of their index operation and again dichotomized them into high and low deductible groups, based on which side of the IRS cutoff their individual deductible fell on. I then ran a multivariate logistic regression with deductible group as my independent variable. My dependent variable was presence of a complicated hernia, and my covariates were age, sex, race, state, comorbidities, and type of hernia. So this is our contour diagram. I started with 77 million patients. I isolated just over 84,000 who underwent a hernia operation for the specified dates. I excluded the top and bottom 0.5th percentile of total cost to get rid of outliers. There were 133 observations where in the low deductible group where costs were less than their total yearly deductible, and I dropped those folks. And then lastly, there was a very small handful of patients where their family annual deductible was a negative value. As this was likely misfiled claims or clerical error, we dropped those folks as well, and that left us with just over 83,000 total analyzed. So here are demographic characteristics. You see that the average age is in their late 40s. However, patients in the high deductible group were slightly younger. The vast majority are men in both groups, which makes sense clinically, and most are white. So I think most of us are familiar with the Charlson Comorbidity Index. It's a tool that calculates 10-year mortality for patients who have a range of comorbid conditions. 5% of patients in the low deductible group had a comorbidity index of 0. Nearly 45% had an index of 1 to 2, and the other half had an index of 3 or greater. You'll see that patients in the high deductible group were just slightly healthier, with nearly 10% having a comorbidity index of 0, about half having an index of 1 to 2, and about 40% having an index of 3 or greater. When looking at type of plan, the majority of patients in the low deductible group were enrolled in family coverage, while most patients in the high deductible group were in individual coverage. And then, as expected by definition, the HDHP group had significantly higher deductibles. So next we have average costs. This was about $12,000 to $13,000 for both groups. And then we have hernia type. Over half in both groups were inguinal, just less than half were ventral, and very few were femoral. And then finally, we have hernia classification, so either uncomplicated or complicated. And as you can see, the percentages are about the same for both groups. So that brings us to our results. And in the interest of time, I'll focus on the multivariate analysis. So first, looking at the full sample, we find that overall, patients enrolled in high deductible health plans were at a 6% higher odds of presenting with a complicated hernia. Looking at just individuals, those enrolled in a high deductible plan were at 9% higher odds of presenting with a complicated hernia, and both of those p-values are statistically significant at the 0.05 level. And finally, looking at patients enrolled in family coverage, those enrolled in a high deductible family plan were at 5% higher odds. However, that odds ratio is not statistically significant at the 0.05 level. So for our secondary analysis, I wanted to understand if there's a positive relationship between deductible amount and odds of presenting with a complicated hernia. To do this, I focused on patients in the high deductible group who were enrolled in individual coverage. So I grouped these patients into tiers. So tier 1 included patients whose deductible was 1 time the IRS cutoff. Tier 2 were patients whose deductible was 2 times the IRS cutoff. And then tier 3 included patients whose deductible was 3 times or greater than the IRS cutoff. I then again ran a multivariate logistic regression with tier as my primary independent variable. Presence of a complicated hernia was my dependent variable, and the covariates were the same as the primary analysis. Results showed that indeed, as the deductible amount increased, so did the odds of presenting with a complicated hernia, ever so slightly, with tier 1 being the lowest at 8% and tier 3 being the highest at 11%. So in terms of limitations, this is an observational study, and it's subject to the limitations of such. We use claims data, so there's potential for misclassification and clerical error. And lastly, there's no evidence that our results are solely due to delay in seeking care. Despite these limitations, with a robust analysis, we found that high deductible health plans were associated with higher odds of presenting with a complicated hernia for patients enrolled in individual coverage. And the higher the deductible, the more likely they are to present with one of these hernias. My thought is that this is due to cost-related delay in seeking care, but more work needs to be done to confirm this hypothesis. While the clinical significance of these odds ratios on the individual patient level may be small, these are very common procedures, and when considering the vast numbers and costs, it really starts to add up. So while high deductible health plans are an appealing alternative to traditional plans, they've been associated with worse patient outcomes, cost-related delay in care, and decreased healthcare utilization. In terms of next steps, I think it would be helpful to look at other general surgery procedures for which delay in care could have an impact on patient outcomes, things like appendicitis, diverticulitis, cholecystitis, and we really need to understand what's really driving these results. Thank you so much for your time, and I'd like to thank my research mentors, Dr. Morris, Dr. Bundorf, and Dr. Liam Rose for their help with this project.
Thank you very much. That was great. How did you make the decision to use charges versus costs in this analysis?
Definitely. So charges are what the hospital is billing insurance companies, and costs are what the insurance companies and the hospitals agree upon, and what actually impacts the patient in terms of out-of-pocket costs. So we felt like that was a more accurate reflection of what was happening in the real world with these patients.
Okay, great. Did your analysis using the CPT codes include both open and minimally invasive repairs?
Yes, it did.
Okay. And another question is, what happens if you look at deductible as a continuous variable rather than as a binary?
That's a great question. My hypothesis is that things would be about the same. It's kind of what we did with our secondary analysis, looking at tier. But that's definitely something to look into.
Did you look at the month of surgery? Because many patients meet their deductible and then seek elective care sort of at the end of the year.
We did look at month of surgery, and I didn't show that data here, but the results were no different.
Okay. And then did you control for patient or family income?
No, we did not. Based on the version of Optum that we had, we didn't have access to that data.
Okay. And then, let's see. Dr. Elber, do you have any questions?
I don't have any questions. I can make a comment. The question you ask is really reflective of how important your work is, and that was a really good question. That was, the scientific methodology was rigorous and interesting. But if it's true that people are avoiding having surgery because their deductible is so high and they don't want to pay it, I mean, that's just a crime. And, the quality of that question to me is reflective of the quality of the work, and I congratulate you.
Thank you so much. I appreciate that.